You know, in our practices, we all have them. Those patients with type 2 diabetes who, no matter what we throw at them, multiple meds, different combinations, they just don't seem to reach their glycemic goals. It's a real clinical headache. But what if there's an underlying cause we're not routinely looking for?
So when you have a patient, maybe they're on several agents, even insulin, and their HbA1c is still stubbornly sitting above 7.5%, what's the next move? The standard playbook says intensify treatment, but the Catalyst trial makes a compelling case for a different approach, to stop and look for a secondary cause, specifically an excess of the stress hormone, cortisol.
Now, get this. The screening phase of the Catalyst study was a real eye-opener. They found that nearly 1 in 4, 23.8% of these patients with hard-to-control type 2 diabetes had endogenous hypercortisolism. And here's the critical part. Most of these patients don't have the classic, obvious physical signs of Cushing syndrome. This means it's incredibly easy to miss.
So how exactly does this excess cortisol sabotage all our efforts? Well, it's a triple threat. It cranks up insulin resistance, it directly impairs the function of our beta cells, and it tells the liver to just pump out more glucose. Basically, it's actively working against every standard diabetes therapy we prescribe.
Okay, so if excess cortisol is the problem, the logical next step is to block its effects at the receptor level. And this is where Mifepristone comes into the picture. Now, you might know this drug from a completely different context, but it turns out it's also a pretty potent metabolic agent.
Mifepristone really has a dual personality. While it's widely known as a progesterone receptor modulator, the key for our purposes is that it's also a powerful glucocorticoid receptor antagonist. It's this GR blockade that's the hero of the story here, counteracting the metabolic chaos caused by hypercortisolism.
So Mifepristone competitively binds to that glucocorticoid receptor, essentially kicking cortisol out of the way. And it's not a fair fight. It has a binding affinity that's about 3 times stronger than even dexamethasone, making it a seriously potent antagonist.
The theory all sounds good, right? But does it actually hold up in a real-world clinical setting? Well, that's exactly what the Catalyst trial set out to discover. It was the first large-scale study to really put this cortisol-directed therapy to the test in patients with both type 2 diabetes and hypercortisolism.
And they didn't mess around. The trial was a solid, randomized, double-blind study. They took 136 patients who fit this specific profile and gave them either Mifepristone or a placebo for 24 weeks. The main thing they were looking for? The change in HbA1c. The results were, to put it mildly, striking. Just look at this chart. The placebo group, well, their HbA1c barely budged. But the Mifepristone group, they saw a huge drop, a mean reduction of almost 1.5%.
When you adjust for the placebo effect, that gives you a difference of a 1.32% reduction in HbA1c. This wasn't just statistically significant, with a p-value less than 0.001. No, this was profoundly, clinically meaningful, especially when you remember this is a treatment-resistant population.
And the good news didn't stop with glycemic control. Patients also saw a placebo-adjusted weight loss of over 5 kilograms. That's more than 11 pounds. And this came with a significant drop in waist circumference, too.
Now, the dramatic results we saw in Catalyst came from using high doses over a pretty long duration. This brings up a really important question. Are the dose and the duration of this GR blockade critical for success? Turns out other research gives us some important clues.
When you compare studies side by side, it becomes crystal clear how critical dose and patient selection really are. You've got Catalyst, using high doses for 24 weeks in patients who actually have hypercortisolism, and they get these major benefits. On the other hand, you have the Gubbi study, which used a much lower dose for only 9 days in people without hypercortisolism, and the results were way more subtle.
What Gubbi and his colleagues found was fascinating. Their short-term, lower-dose regimen didn't change whole-body insulin sensitivity at all. But they did see very specific effects in certain tissues, improved insulin sensitivity in fat tissue, and a trend towards improvement in the liver. This really points to a dose-dependent and tissue-specific response.
So, those potent benefits we saw in Catalyst, they don't come for free. There's a pretty significant side effect profile we have to talk about. This is not a therapy you can just prescribe and forget. It absolutely requires proactive monitoring and management.
The good news is the adverse events are predictable. They're direct consequences of the drug's mechanism. When you block the GR receptor, the body freaks out a bit and pumps out more ACTH and cortisol. This excess cortisol can then spill over and activate mineralocorticoid receptors, causing issues like hypokalemia and edema. Other things, like fatigue and nausea, are basically symptoms of cortisol withdrawal.
And these side effects have very real-world consequences. The discontinuation rate in the Mifepristone arm of the study was 46%. Almost half the patients stopped the drug. That's a huge challenge, and it really underscores the need for aggressive management and patient education right from day one.
And we have to talk about hypoglycemia. This case report in a patient with type 1 diabetes really highlights how potent this drug is. Cortisol is one of our key counter-regulatory hormones. By blocking its action, Mifepristone can dramatically increase the risk of hypoglycemia. That's a critical safety concern for any patient on insulin or sulfonylureas.
So if you're going to use this therapy, you need a plan. A proactive protocol is essential. Step 1, manage potassium, probably by starting with a potassium-sparing diuretic. 2, educate patients about what cortisol withdrawal feels like. 3, monitor glucose like a hawk, and be ready to aggressively deprescribe insulin and sulfonylureas. And finally, number 4, watch carefully for signs of mineralocorticoid excess like edema and high blood pressure.
All right, so after all that, what's the final verdict? Is targeting cortisol a real viable pathway for certain patients with type 2 diabetes? Let's step back and weigh the evidence.
The balance sheet here is pretty clear. On one side, the benefits, a major drop in HbA1c and significant weight loss, are profound. But on the other side, they're matched by some substantial risks, including that very high discontinuation rate and side effects that demand vigilant, hands-on clinical monitoring.
This really brings us to the importance of patient selection. This is not for everyone. The ideal candidate has uncontrolled type 2 diabetes with confirmed hypercortisolism, and, just as importantly, they have to be both able and willing to stick with rigorous monitoring and manage the potential side effects.
And this all leads us to a final, really practical question for our own practices. The Catalyst data suggests that nearly a quarter of our toughest-to-treat diabetes patients might have an underlying and potentially treatable hormonal problem. So given these findings, should a dexamethasone suppression test become a more routine part of their workup? That's definitely something for all of us to consider.